don't have to achieve power when we are rehabbing rotator cuff. It's about precision. So the timeline is not the guarantee that he is well. It's very subjective. So now this criteria based rehab converts these mechanical variables into the measurable milestone. ER-IR ratio is very important when we are rehabbing the joint. So we are talking about whether the both limb symmetry is there. That is very important. The rehab journey, when you start the journey, the apprehension, because every athlete is new to you. And when we plan a rehab setup for them, so it's not that, it's very subjective. So someone is, how we are planning for each and every, it's a tailored made for each and every individual. It's not that you have a fixed plan. And now when you talk about shoulder, now, recently, when we are all talking about this is all new, that only it has to be criteria based. What is it? The timeline, a healing tendon, when we talk about a rotator cuff. So it's just not that key, you have to just go through the timeline. The tendon, the healing tendon, it's just did not respond to load, but not to time, but to loads when it's, the magnitude, the direction, the frequency, and the rate. So these, when we talk about criteria-based rehab, so now this criteria-based rehab converts these mechanical variables into the measurable milestones. So the progression is both safe and scientific, because once we are sticking to the timeline, suppose a tendon has not healed for athlete or a patient, and we are moving to the second phase. So the timeline is not the guarantee that he is recovering well. So now when we talk about the tendon, how it is healed, how it is taking the load, whether it is uh, uh, taking load in all the directions, taking multiple, because the shoulder has multiple roles like pushing, pulling, carrying over, lifting. So when we talk about a shoulder, we have to think in multiple planes. How many of you have seen a rotator cuff patient? Okay, fine.
Yes.
So when we talk about the rehab, if we are talking about the conservative approach, so we have to establish there are some functionals, functional limitations of shoulder, and then what all the functions so shoulder can do. So all the exercises, all the rehab plans are designed on these few functional patterns of the shoulder, whether it is pushing, whether it is pulling, whether it is a lifting. So when we talk about first phase, initially when a patient comes to us, whether he's an operative patient or whether it is a conservative approach, because he has, while playing, he has injured his muscle, whether it is a small tear, whether it is a subscap involved or a supra involved. So what we have to establish, because in each phase, what we have to do is we have to see whether the patient or whether the athlete is able to move in the second phase. Now, the primary goal should be to, if he is coming to my department, he's coming with lots of pain and loss of movement. So initially, we have to restore that pain thing and the movement thing. We have to restore both. So controlling pain, we have, of course, the modalities and everything. So the initial phase is a very cliche phase where you are using your, cold fermentation and establishing that on a vast scale, the pain actually, it's, if it is like 5 or 6, we have to bring down the pain. So, and also to first we have to get the movements for, and not just the joint which is involved, about the distal extremity. So whether it is elbow or wrist, we have to establish that those are, in movement. So first priority in the phase 1 is protection wherever the injury has happened. And then we move on to this thing that we have to establish the range. So initially, in the initial phase, that is like 0 to 4 weeks of the injury. And if it is a conservative, like he has just torn it, nowadays what I practice in my OPD is like I go fast with them. It's not that you have to tell them you have to protect. If it is just a conservative approach, you just go. If they have, like, they are holding, like, the endurance capacity, if they are holding it 90 degrees, they are lifting it, straight raises are good, the abductors are good, the scapular pattern is good, so you can move on to the second phase. As I told, it's not any timeline because it's very subjective. And also the muscle memory is there. If he's a player, he knows how to do it. So the rotator cuff, basically what it is like, where biology meets physics. Rotator cuff ka primary role is to a dynamic stabilizer. So it's not about power. We don't have to achieve power when we are rehabbing rotator cuff. It's about precision. How, and it's about reflex stabilization. कोई force कैसे आ रहा है? That's what the rotator muscles do. And also centering the glenoid in the humerus. That is because it's a force which stabilizes the glenoid in the humerus. So it's not only about the strength and power. It's about when you are rehabbing the athlete, you have to focus on all these parameters. You have to establish the neuromuscular control, you have to establish the proprioception and everything. So when we talk about rotator cuff, all these roles and all these parameters have to be taken into control. So when it comes to the first phase, again, it's like, the vein has to be controlled, the tear has to be protected. Also, it depends on the surgery, if it is a single row repair or a double row repair. So when we talk about the parameters, as Anmol said, the ER and IR ratio, that is a very important. When I see in my OPD in my clinic, so I think that is a very important biomechanical marker when it comes to ER-IR ratio. Why? Because one acts as an accelerator and one acts as a decelerator. So जब हमारा ER जो all these infraspinatus and teres minor, the prime, the external rotators, they help. And infraspinatus is like, the prime, whenever we are joint, force is applied, it holds the joint. It reacts to the force. So that is very important. The ER-IR ratio is very important when we are rehabbing the joint. Now coming to the early strength phase, the rebuild phase. First thing is the symmetry. When we are talking about, yes, the movements is established. It should be like 90 to 120 degrees. You have established the range. You have established the scapular pattern. The scapula, good scapular humeral rhythm is there. So we move on to the next phase. When we all these things, not just like the first phase or the second phase. The initial phases are all about pain control and protecting the repair. But when we move on to the second phase or the third phase, where the actual strength phase is happening. So when we see about a thrower, when we see if as a player is a thrower, there are several protocols which we use in our department. You can use a thrower's protocol. There is like W's, Y's, and T's. All happens to stabilize the rotator back muscles when we are integrating the posterior chain. So that is very important. Again, the symmetry, when we are talking about in the second phase, we are third phase when we have entered. So we are talking about whether the both limb symmetry is there. That is very important. And all those W, Y's, T's, you have to scapular clocks, you can initiate the movements. And also uh, close chain exercises are very important in this phase.